to talk about how we can approach a patient who's coming with first unprovoked seizure. So first I'll give an introduction and background a little bit, and then how we can approach a patient from the emergency setting, and then the diagnostic testing, the drug therapy, and the discharge and family education, and lastly, references. So as you know, the seizure is always an event that causes significant anxiety for the parents. And the first unprovoked seizure is the first seizure that happens without an immediate precipitating event. And the etiology can be either symptomatic cause, like relating to a very exciting brain abnormality, insult, or in most of the cases, it could be cryptogenic or idiopathic, as we can say. So, Scott, talking now about how we can assess those patients from the emergency setting, you know that we should start from basic assessment, including the vital signs, and then assess the patient from A, B, C, D, and continue providing information about the seizure and document it and take the aspiration precautions, keep the patient on the left lateral position and provide the oxygen, and then you should follow the status epilepticus protocol. So we will start with the full history obtained by seizure first from any dependable witness. So when did the seizure occur, and how long it lasted, and how did it start, and how did it look like? And was there a post-ictal state, and how long was it? And how was the child acting before the seizure and after the seizure? And then you should ask if there is any recent exposures like chemicals, industrial, and does the child have a current illness, indications of trauma or abuse, any previous seizures within the child or the family, and any history of developmental delay or neuroregression, and the immunization history as well. Then you should list the medications that the patient is taking, including any antibiotics, anticonvulsant. If the patient is already on, you should know the dose exactly and the timing that the patient have received the last dose. And then you should do a full physical examination. Those children require a really thorough examination, starting with the conscious level. Then you do the vital signs, cardiovascular exam, head circumference, and if there is any signs of dysmorphism or neurocutaneous markers, neurological assessment. And after that, you will think whether you will need to admit this child or not. So now talking about the admissions, there are specific indications where you will consider admitting those children. So first thing is the age. The age limit is 18 months. If less than 18 months, this is an indication to admit these patients. And in other resources, they mentioned 6 months. And then in the neurological status of the child, the GCS, and how is he post-ictal or on your assessment now? And if there is any neurological signs. Sorry for my voice, I'm having viral illness. And then if there is any signs of raised intracranial pressure like papilledema or tense fontanelles, if there is a general patient appears generally unwell, irritable, or vomiting, only meningitic signs, photophobia, neck stiffness, Kernick sign, positive, for example. And then the nature of the seizure itself, if it is like presenting acutely with a duration of more than 10 minutes or 5 minutes now as per the latest status epilepticus protocol if it is focal or recurrent or required emergency treatment. And if there is any signs of aspiration in terms of respiratory distress or the need of oxygen, or if there is a high parental or carer anxiety, like the parents are really anxious and they are like unhappy to go home. And then we will go to the lab investigations. So in the lab investigations, almost all the guidelines, they are recommending to send lab investigations based on the clinical circumstances of the child. So if there is like any abnormality post-ictally, then you can think of doing those lab investigations. Because why? Because if the patient is had a seizure, for example, due to electrolyte imbalance, it wouldn't stop, and the patient would not be fully like back to his normal status if there was an abnormality without correcting it. So what are the investigations that might be like needed? CBC with differentials, blood glucose electrolytes, including calcium, magnesium, phosphorus, the urine drug toxicology screen, and the ECG. In some resources, it was mentioned as well. Lumbar puncture is not like routinely done if the patient is like alert oriented. It shouldn't be done unless there is like altered mental status, signs of meningitis or encephalitis, or if it was a prolonged like atypical presentations, or if the patient is immunocompromised. Um, then we'll talk about EEG. So do we need to do an EEG for all these patients who are coming with first unprovoked or not febrile seizure? The answer is yes, as per American Academy of Neurology, Pediatrics. They are recommending to do it after for all children who are coming with a seizure. So the other question is, when do we do it? So this is again a debatable question. Some guidelines uh, prefer to do it as within the first 24 hours. But you should really be careful if you are doing it in the first 24 hours, because if it is done, then it will show abnormalities post-ictal. And the physician should be aware that there are some abnormalities like post-ictal slowing that can be seen normally within 24 to 48 hours of the seizure. And this can be like transient, and it should be interpreted as with caution. In the other resources, they mentioned that EEG it shouldn't be done as an emergency, especially that the availability of urgent EEG is often limited. So you can discharge the patient and give him as an outpatient appointment. And always this EEG should be interpreted by a pediatric neurologist who is expert in this field. So now the other thing is that why do we need EEG and what can it help you with? So you should know that EEG is not a diagnostic tool. Um, uh, why is that? Because in some of the patients who are really having epilepsy, they might have a normal EEG, while in others who are not having seizures, they might have an um, uh, an uh, and electrical discharges, which is again not indicative of epilepsy. So why do we need to do it? It will determine that the epilepsy syndromes, if it is there. So you can know in specific with specific findings that the risk of recurrence is high, for example. And then you will help you to classify the type of seizure, and it will influence also performing additional neuroimaging studies. Like, for example, if you see the EEGs with a focal discharge is coming from specific area from the brain, then you might think of a structural abnormality in which you will need to do neuroimaging. Coming to the neuroimaging. So, what is the best neuroimages in general? The answer is always MRI, but as you know, it is not always available as on urgent basis. So, when do we need to image this patient urgently? To use the CT scan. It shouldn't be done again routinely for all patients who are coming with the seizure, with normal development and normal examination. They usually don't require neuroimaging. In many instances, the first seizure actually prompts an evaluation in the emergency, and CT is usually frequently performed actually. Although this is not necessarily the optimal practice due to the radiation risk and the lower yield. So it should be limited to cases where there is a suggestion of like acute intracranial process, significant acute cognitive or motor impairment, if there is a new focal deficit not resolving, and the patient is not returning to his baseline. So MRI, when do we need to do MRI? MRI should be considered um, uh, in uh, in any child with significant like cognitive or motor impairment. If the child is less than 1 year of age, and others guidelines they mentioned 3 years, or if there is abnormality in the neurological exam post-hospital as well, and if there is focal onset without generalization, or if there is abnormal EEG. Some of the points we already mentioned. So abnormalities again in the MRI can be seen in 1/3 of the patient. However, some of them they don't influence or require any treatment or management. Um, sorry. One of the common questions that we will be asked from the parents, what is the recurrence risk? So the majority of children who experience an unprovoked seizure will have few or no recurrences. Like 10% will go on to have another seizure. Um, and what are the predictors for us to consider the recurrence is if there is abnormal EEG, if there is underlying etiology, if there is abnormal neurological exam, example if the feast seizures prolonged, recurrent, are more likely, like if the patient came with a status, then it is more likely that this patient will have another seizure. So when do we start those patients on treatment, or when do we consider the anti-epileptic medications? So, sorry. So the prophylactic medications is not usually initiated after the first unprovoked seizure, unless there are other factors, as we already mentioned, like that increases the risk of recurrence, like if it is a status epilepticus, or if there is abnormality structurally, or in EEG, sometimes specific results will prompt you to think that there is a risk of recurrence, or if there's structural abnormalities seen on neuroimaging. And then if we talk about the type of medication, again, it should be depending on the type, frequency, the severity. You should think about side effects. If the patient is already on other medications, the drug interactions. And again, it should be also a discussion with the parents, and it should be started by a neurologist. What are the drug therapies that we are starting? So like in case of absence seizure, isotretinoin, lamotrigine, focal seizure or generalized, there is some overlap between the medications. Actually, Keppra nowadays is frequently used in focal and in generalized seizures as well. Oxycarbamazepine in focal seizures, topiramate, focal or generalized, and valproic acid. Um, so what things that you should make sure that you inform those parents before discharging this patient home? You should they should they should know how they where they will follow um, later after discharging those patients, and you should give them a plan for outpatient EEG, support them, and consider rescue treatments if there is again history like suggestive of recurrence or any indications of recurrence. And you should tell them how they can deal with the seizure if it happens again. It should be positioning the child on left lateral position, protect the head from injuries. That if he's on like a high distance, for example, table or the bed or something, he might fall down. Or if there is anything around him that might injure him, if the clothes are tight, to loosen them and. I never try to put anything inside the child's mouth, as it might also push the tongue backward and cause further respiratory compromise. Or the one who's putting his hand inside, he might injure the child because you know that this is involuntary movements. Instruct them how to use the ambulance, and uh, if it happens again, that they should video record it. And swimming alone is not allowed. They can swim, but with someone who is trained in swimming under supervision, and no driving until cleared. Um, Here are some of the, again, other questions that might be asked. How likely is the child will have a seizure? I think we already answered that question. And what is the risk of dying from seizure if they don't start medications? So sudden unexpected death is very uncommon. And again, it depends on the patient's neurological status, actually. But from only a seizure, it is common. And there are no studies showing the treatment after a first seizure will alter the small risk of sudden death. So, in summary, EEG should be obtained in all children in whom the febrile seizure has been diagnosed, and to predict the risk of recurrence, classify the seizure time and epilepsy syndrome. The decision to perform other studies, including LP labs, neuroimaging, for the purpose of determining the cause and detect the treatable abnormalities will depend on the age of the child and the specific clinical circumstances. Most of the well-appearing children can be managed as outpatient after a first febrile seizure, with instructions for an outpatient EEG and follow-up. So those are my references. And if you have any questions, you're welcome to ask. Seems that no one is here apart from Dr. Rali and Dr. Tamanni. Anyhow, thank you very much for attending. Thank you for listening and your time.